top there, I want to highlight, has to do with concerns that came up about the ways that, stigma, competing family demands, and practical challenges could potentially interfere with participation. And so we thus define this strategy that we call relentless engagement, which includes consistent weekly communication. Where's Tushi? She can tell you all about this. I forgot to call you out on our team slide. So what am I talking about? Relentless communication, consistent phone calls and WhatsApp to really support relationship building and encouraging participation. So those just give you sort of a highlight of maybe 2 areas that led to a lot of changes. So our new model, as I said, is called Cafés 2, and we call that a peer-led family and social strengthening intervention. And this slide gives you kind of a visual picture of the program, and it's actually excerpted from that journey map. So it indicates that the first step is that families receive a home visit. The purpose of that home visit is really to provide information about Cafés 2, to build relationship with the peer providers, and to really work with the families to gain their commitment to fully participate in the program during the next 6 weeks. After that, families receive a reminder call, they receive a WhatsApp message, they travel to the public library, they attend the meeting with other families, travel back home. We have those different activities that are meant to continue in between group meetings, and then essentially they repeat that cycle 6 different times. Given that this is really conceptualized as a prevention-oriented model and delivered by peers, we're really focusing very much in Cafés 2 on present challenges and concerns, and very deliberate about not including content or expectations to discuss past traumatic events. In the middle phase of the intervention, we do ask families to reflect back on their early resettlement experiences in Chicago, but mostly as a way of encouraging them to reflect on the strengths that they drew upon and utilized. And then in the later phases of the model, we kind of shift to a future orientation. And activities have to do with clarifying hopes and dreams for their families now in this new phase of their life. And discussion concludes with a discussion of informal and formal resources that are important for accomplishing that vision for their family. Each group meeting is structured around a key family process, and each meeting includes components that have to do with developing skills to cope with stress and mental health, strengthening families and social connections, and that relates back to those early findings you might remember from our formative work. So attention, we call this our Cafés 2 placemat, and it just kind of highlights all the different tools that are part of the intervention package. And just to say that attention to design aspects of the intervention, including co-designing the logo mark with participants, testing the color palette. We tested tools in co-design sessions and subsequent interviews for engagement, for readability. All the tools were designed really with the ultimate goal of being able to replicate them readily in community-based organizations. So for example, all were designed to be able to be printed and cut if costs prohibited the production of certain resources. And then to build, we were again really focused on building emotion regulation skills and augmenting those mental health components. And so to accomplish that, we adapted 6 trauma-informed mindfulness skills that were integrated into Cafés 2, and these skills had to do with mindful breathing, grounding in the present moment, body awareness, acceptance, and so on. And these skills are sequenced throughout the program to enable participants to really build skills gradually and progress towards more complex skills. And then to facilitate their use of skills at home, again, I talked about the designing for kind of diffusion idea and being able to share this information with families. We developed these, what we call our skills cards. They're Arabic on one side, English on the other, as are all our program materials. And so families receive these at the end of each group meeting, and they're encouraged to utilize these 3 to 5 minutes every day over the course of the next week. We also thought a lot about the facilitator's handbook. I spent a lot of my life before I was involved in research, developing different curricula and interventions, and often have nightmares thinking about like these 200-page Word documents that we produced, which were kind of awful and impossible to use. So we thought a lot about, what would peers, especially folks who maybe hadn't engaged in this kind of work before, how could we best structure the facilitator's handbook to enable really easy access and utilization of the intervention materials? So what is highlighted on this page at the top, for example, is a dashboard that reminds peers of the goals of this particular topic, of the timing of it, of the materials they need. We have notes to peers that are integrated throughout the handbook that remind them of core competencies that they should draw upon, areas where notes can be taken, and so on. So what you see up here now are just some testimonial excerpts that were shared from our co-design team members that speak to, I think, the useful, the dynamic, and the collaborative nature of the process. So just to share one from one of our partner co-design team members, I really enjoyed this collaborative approach, taking our time to develop our thoughts and carefully sculpt the program. The project moved at the speed of trust and care. So in addition to the specific adaptations, I want to discuss some of the process findings from this adaptation undertaking. First, I want to go back and just reemphasize something I said earlier, which is that, how am I doing on time? Okay, I'm coming to the end here. First is that I really think that these design tools I talked about, these artifacts, these probes, these prototypes, really help to enable structured and direct interactions with the intervention and revealed really important opportunities for strengthening the model. I think the participatory and collaborative design really enabled integration of individuals with diverse lived experience into the entire adaptation life cycle. And then I think finally, thinking about community partnerships, it really fostered a context of trust with families, with our partners, and a real sense of shared investment and ownership, and which we see the benefits of now that we're at the pilot trial stage. And we certainly hope continues into sustainment, and integration of the model, of course, pending results from our trials. So I want to conclude by just giving you a snapshot of where we are with our trial. We launched our clinical trial of Cafés 2 in May, and that began with selection, recruitment, training of our peer providers, which has gone really well. We're conducting the trial in kind of cohorts, and so we have completed our first cohort of Cafés 2, and our second one is underway. And our ultimate goal is to recruit 74 families. We are using a randomized design, so 37 families are randomized to Cafés 2, and then 37 receive enhanced care as usual, which involves receiving some additional materials on healthy lifestyles. I do want to just make mention about our peer providers. So we, in addition to those earlier conceptual models, I'm going to sneak another one in here, which is that it's really based on this peer service model where individuals with lived experience deliver the intervention. The idea is that peers can draw on their own lived experience and reduce stigma and promote engagement, and then serve as a role model and a source of support to families. So a question kind of coming into this project is, how do we conceptualize peerness in the context of prevention-oriented mental health, and also in the context of services for newcomer families, which really hasn't, the peer models that are so present in substance use and care for severe mental illness, or even in child behavioral health, has not made its way into refugee service settings. So we actually have a whole other kind of line of work that we're doing related to that, but that led us to really give some careful thought to how we defined what were the critical kind of lived experience criteria for peers in Cafés 2. And so what we came down to, and we'll be learning about this through our pilot, is shared cultural and linguistic background, shared experience of resettlement, and navigating personal, familial, and social challenges associated with resettlement. And then third, also thinking of this as a family model that involves young people and adults' shared experience, either as a caregiver or as a young person who had navigated that life experience. So So we're very excited actually about that peer-related work. So who is eligible to participate in this Cafés 2 trial? So it has to originally be from an Arabic-speaking country in the Middle East, Syria, Iraq, Jordan, Lebanon, Palestine, or Yemen. A family is considered at least one caregiver and one adolescent aged 12 to 17 years old. We were really targeting the adolescent period in Cafés 2. And they have to be living in the same household. And then because we're thinking of this as a selective prevention intervention, at least one family member has to be have moderate emotional distress, which we operationalize as a score of 3 or greater on the general health questionnaire, which is a pretty common screener for common mental health problems. So we're mostly really concerned with feasibility, given that this is a pilot trial. And we are conducting a mixed methods pre-post design to examine our implementation outcomes. We're also collecting implementation process measures to further assess feasibility and acceptability, and to look especially at patterns of attendance and retention, which are often extraordinarily challenging in family-based mental health, not to mention groups of families. So to explore and then to think about outcomes, what are we doing? We're following randomized families at 3 time points, pre-intervention, post, and then 6-week follow-up. And looking for and we'll be examining an exploration of differences between families in Cafés 2 and those in the control group in terms of a number of different mental health outcomes, anxiety, depression, PTSD, and stress, and a number of family functioning outcomes, and then also social support and help seeking. So, we're so early in this, we're really in the thick of it all. It was kind of challenging to think, what can I take away at this point? But I was like, I got to have something. So just very initial takeaways where I stand now in terms of the pilot. First, I think I just want to say that so far, it's early on, but we've had a lot of success with recruiting, training, and retaining peers. And they've been able thus far to really maintain fidelity to the model in implementation. We've seen an extraordinarily positive response so far from our partners, from our peers, and from families to the content in Cafés 2. They see it as applicable, as important to their life, and are finding ways that they can make use of it in their daily life. So that's, those have come through our post-intervention interviews, which I've been part of most of. I think the other really important highlight at this point is just reflecting on strong relationships with trusted partners and how important that has been for successful recruitment. We've done a ton and engaged in a ton of passive recruitment efforts, and that has yielded almost zero interest. It really takes trusted folks reaching out to families that they know are eligible. And to date, we've had 100% of families completed baseline, post, and 6-week follow-up. So I'll take that success for now. On the flip side, I think is just being mindful of the challenging nature of doing this kind of work with resettling populations who are constantly changing. And that's especially been the case in the last few years. When I wrote this grant to NIMH, that was before Kabul fell. That was before the war in Ukraine. That was before lots and lots of families arriving at the southern border. And now people are like, what Syrians, So just to say, we face a dilemma in terms of how do we do rigorous research, but also be responsive to the changing nature of the communities that are arriving to the US. And then I think just the future is unknown. We have conducted this study at a moment of tremendous political will in terms of mental health services for newcomer families. We've seen a $110 million increase in federal funding for mental health under the Biden administration. I think, just these converging issues of post-COVID, of the current administration, has converged and created this moment of opportunity. But, the pendulum has, and might swing again. And so, what does that mean for these lessons learned? So those are my closing thoughts. I want to thank you so much for hanging in there with me through this kind of tour de force of what we've been up to. please, follow our progress on our website, and thanks again.
Questions?
Very interesting, and I have lots of questions, but, oh, okay. Yeah, very interesting. I have lots of questions, but one in particular. I think I heard you say that some of the services were delivered in schools. Did I hear you say that?
I think, go ahead,
Yeah.
finish your question.
So what does that look like? Do you collaborate with the school teams that are already there, or do you bring your own teams in, and how does that work?
So, yeah, great question. Previously, there is a multiple family group model that has been delivered in school settings. We are not doing that in our pilot trial, but there has been a successful pilot study of a multiple family group model actually in a humanitarian context with refugee families. So I can't really speak to the particulars of that, but school-based mental health interventions are somewhat, common in this area of work. And I think it's an important context where you can capture families, and it's a place where families are already going. I think on the flip side, what people learn is that, teachers and educational staff are already so overburdened with the tasks that they have in front of them that it's, often requires pulling them into new services, which is where I think some of the challenges can arise. But I think that's, such an important potential setting to really deliver care and capture families. Yeah.
Thanks so much, Mary. That's super interesting. So yeah, I also have a lot of questions, but I'll try to keep it to just one or two.
Sure.
So it sounds like you mentioned the libraries. Is that the main place where it's being implemented? Is the libraries, and then the community-based organizations go to the library? I was a little bit confused how,
sure.
if they're a community-based organization, why don't they provide it at their organization, or just sort of how that's happening in situation. And then the second question, which I think just as probably shows my ignorance around thinking about therapeutic interventions, but the family group model approach, why is that desired as opposed to, is it because of it's what's the purpose for that? Is it economies of scale in a way, or
Sure.
sort of how yeah.
Yeah, good. So to your first question, what is the role of the CBOs versus the library? So during our adaptation, we talk through the importance of having these services delivered in very accessible neighborhood, non-stigmatizing community settings. The other thing is when you work with families, you got to be able to deliver services at the weekend, after hours. Some of our community-based organizations simply don't have space available to host a kind of group like this. We need enough space to have 6 to 8 families together. We need spaces for breakout activities. But we really thought that hosting them in library settings or other similar community settings were consistent with our overarching focus on situating these services so that families could continue to access those spaces even after formal benefits or the formal program ended. So CBOs are really working in lockstep with us. One neat thing that's come out of this library partnership is they've been interested in offering kind of optional library sessions to participating families. And the libraries have all kinds of services that are super relevant for newcomer families, and also this kind of prevention timing. How to get a library card, ESL resources that are available within the library. They have resume development classes. So it's a neat possibility. Yeah, and then the multiple family group. Why the multiple family group model? So I think that really the rationale has to do with the groupness of the intervention. That certainly there's benefits to delivering services to individual families, but you miss the opportunity to make those social connections if you're only delivering it to one family. And so kind of, that stands out as a kind of unique potential benefit of group interventions, that they have the potential to really kind of restore those social relational resources in ways that other interventions simply can't, because they are delivered to an individual or an individual group of families, or an individual family. Yeah. Great question. Sure.
How do you deal with sort of intersectionalities that might arise in this? Many of the people that are in mental pain in these communities could be experiencing gender discrimination or issues around sexual orientation or other issues. And how do you address those kinds of issues with an intervention of this nature?
Yeah. So I think, the heterogeneity of the group is a important factor, and it has implications for training peers around how do you facilitate a group that could potentially include families from multiple different countries of origin who've had different life experiences, who come in at different places and on a spectrum of norms related to gender, social norms, family norms. So we're making our way. So, so far it's worked okay. And we made that decision, Harold, really from a pragmatic point of view, because what we've seen, especially in mental health services research with newcomer communities, is the development of these kind of single country of origin models. For Syrian families, for Iraqi families, for Congolese families, but those have really you talk about the implementation gap. You present that to service providers and it's like, well, that's great, but I work with families from all over the world. And so a model designed specifically for Congolese families or particular types of, let's say traumatic experiences, has limited pragmatic utility. And so we thought about language as a precondition for composing the group. We know very little about these kinds of things, though, in group models overall. How does the degree of homogeneity or heterogeneity across a range of variables? We don't know, the science is not there yet. We'll be looking at some of those variables, at least in terms of country of origin, the degree of distress within families, as part of our pilot, but that's a lot more work has to be done in that area. Yeah.
You mentioned anxiety, depression, PTSD, stress.
Yeah.
Depending on how this election turns out, are people from the Middle East worried about being rounded up and shipped out of here?
Right. That's what absolutely. Of course. Yeah. So kind of capturing that timing, depending on where we find ourselves at the end of next week, will be really important to look at in our sample. And, that's what I meant by the future is unknown, this kind of great existential threat that looms for any kind of work with displaced families. It's a huge question. Not thus far. Yeah, not thus far. Not in the groups, let's say, but certainly these are big conversations with our community partners, with our peers, with our study teams. Yeah.
So I was wondering, I can obviously see, like you can imagine the traumas that would happen before arriving here, but it also seems like being here and adjusting to this,
Yeah.
just diametrically different culture where
Sure.
it's less family centered and it's, especially in a city center, it's just a really different life. So I guess do you also help them sort of adapt to being here and sort of help connect to other supports for sort of like the next part of the journey once they've sort of kind of settled?
Yeah, really good question. In fact, that's really our primary focus, is what's really emerged in our literature is called the daily stressors model. And there's been some really important research led by Kim Miller and Andy Rasmussen that's looked at that stressors resulting from all those things you just discussed account for a greater degree of the variation in mental health outcomes than do those kind of what we used to be fixated and fascinated with, which is the sort of big T trauma, for lack of a better term. So yeah, we're really focused. That's what I mean. We're keeping our focus on present day how are families coping and how can they kind of strengthen and solidify their family and their social support resources given the tremendous challenges that they're facing. And also, skills for families, how do you work through these conflicts, particularly within adolescent and parent relationships and communications, building communication skills. So we are pretty squarely focused on those huge challenges that you just outlined. Yeah, thanks for asking about that.
Thank you.
So I'm going to flip that question maybe a little bit and ask,
Okay.
you mentioned socio-national losses, and I think for anyone who emigrates from a country, even voluntarily, there is something of a loss. And when you're ripped away from a country, there's so much more involved. But for the U.S., are there items where U.S.-based interventions, those of us who may be born and raised in this country and feel that that individual model, that model of a nuclear family that we're so accustomed to is maybe the only way, and yet there are so many things we can learn, not romantically, but actually learn from other cultures and from other perspectives. Are there things that were coming out, even as you designed this, where it was, this could be very interesting to use in another setting where someone may not, in fact, be part of this community,
Sure.
but the way these communities approach things would be very beneficial?
Yeah, good question. That's a thinker question.
Sorry.
No.
You got like, what, 30 seconds?
I think that there's kind of a little bit of a fiction of this individualized, autonomous, volitional self, right? Like, that doesn't work for me. So I think all of these much more socially rooted kind of collective orientations. Do we need more evidence coming out of COVID to demonstrate to us that we're deeply social beings? We need other people. The resounding evidence vis-a-vis social support is not specific to refugees. I mean, the literature is much stronger for non-refugee communities. So, and what we've found, so I think in short, yes, bringing family, and these ideas of bringing families together, peer supports, these occur in also naturalistic ways too, right? Here it's kind of in the context of a prevention model, but we can think about, Cafés was named after the common ritual of coming together to drink coffee and tea in Bosnian and Kosovar communities. And so I think, we can think about similar analogs that exist in our own cultures that really emphasize the importance of social relational resources for our well-being. Yeah.
Any more questions?
No, you're good.
Okay.
Thank you, Mary.
I'm sweating it up here. No, I really appreciate all the questions.
Thank you for the talk. I was curious, just hearing from other Middle Eastern people that, especially with what's happening in Palestine, they feel a loss of safety and security, which obviously really impacts their mental health. And as it's an ongoing thing,
Yeah.
I'm wondering how that has entered the space and what has been the response and how you've been working with it.
To date, we have not enrolled any Palestinian families, even though Chicago has the largest Palestinian community. Most families that are here from Palestine don't meet some of our core requirements, and sadly, there aren't new families being resettled here. So we haven't entered in that yet. However, I just learned that in cohort 2, we do have a newly enrolled Palestinian family. And so I'm really interested to see how that shapes our group, how that enters in the conversation. Yeah.
Are there like Syrians or others who also get impacted? So like not even with Palestinians, but other Middle Eastern.
Sure.
So from other countries that also, especially from what I know, I wasn't here during 9/11, but there was a lot of violence towards all brown people. So I think there's something similar that's happening right now,
Sure.
where not just Palestinians are feeling unsafe, but Arabs in general or Middle Eastern people or brown people.
Sure. Yeah, I think this is what kind of along the lines of what our other participant asked as well. Let's see how to best respond to that. How has that come up? I think that one of the things is that a lot of families it's sometimes surprising what isn't being discussed, which doesn't mean it's not a priority. It just may not be what's being discussed. So that's one thing, what's not being talked about is as important to think about as what is being talked about. I just had another thought that dropped out of my mind. Secondly, I was going to say, so we've really targeted this for families in the early phases of resettlement. And so a lot of those families, I think, are feeling pretty chaotic about having newly arrived. They're still trying to get their bearings. And so a lot of times I think that sort of subsumes their whole total thinking, which might be why we're not hearing more about it. But, one thing that has been communicated to us on the positive side is, and this is really from the outset of undertaking this study and the adaptation, is people feeling seen and heard by the focus on Arabic-speaking families from the Middle East, feeling like invisible, feeling like they've never had the chance to talk, to think about the needs of their community in this way. So that's been really, really very powerful. And I think we'll stay tuned sort of for how things further evolve over the course of the trial. Yeah, thanks for that question.
Yeah, thanks, Mary. Just get in one more question.
Sure.
With the adaptation, and my question is kind of related to the last remark you made about, when you first designed this, Syrians were, the major group of new coming families, but today it looks quite different.
Right.
And so I guess it raised in my mind two things. One is when you did the adaptation, could you give us an example of what was one of the biggest adaptations specifically for this group, for Middle Eastern families from the Middle East? And then what would you have to do? Do you have to go through the entire process again to do it for Venezuelan families, for example? Or do
Right.
you have hope that once you when you think about sustainability, can you move more quickly to adapt it for another group when we think about, this is a long time to get it in place, so.
I think that is such an important question, and it's such an area where the field needs to go, which is in terms of like really articulating rapid but rigorous adaptation processes, right? This is supposed to help us close that development to implementation gap. But you're right, it's a year long, it's a huge investment in resources. So I think, one option is like, and we have had tremendous interest actually from schools, from community groups, to say, can we make this available to Spanish-speaking families, Darien Pashto-speaking families, Congolese families, to say, sort of start with a pilot and, translation and training of peers, and you could do some small adaptations even through that training process, and then pilot it and let the needs for adaptation come to light through that pilot process versus this kind of front-loading approach. But I think that is where we need to go, because we have service providers who are like an urgent, really hungry for these kinds of models, and an inability from a scientific perspective to really respond in a timely manner. In terms of like what were the biggest changes that were made perhaps for Middle Eastern communities, let me think about that. One thing which was reveals what happens, I think, also a lot, which is this say-do gap. But through adaptation, we kept hearing, like, forget it. You're never going to get dads to show up to this. Are you kidding me? Like, moms are going to be the one to show up. There's no way, culturally, this is going to be seen as the work of mothers. And I don't, this has probably never happened to any of you, but I had this experience of walking through this process and kind of going like, yeah. Not giving it the full weight that it needed until latter stages of the adaptation. Like, we need to take this really seriously. This is kind of cuts at the beating heart of the intervention, which is the idea of bringing a whole family together. And so that's where this designing for diffusion came up. How can we reach fathers even if they aren't able, willing, socially sanctioned to attend? But guess who's showing up? Dads. and moms in very big ways, you know. So we made all these modifications kind of more mindful of family roles, social roles, gender roles, and then it's kind of showing itself in different ways now that we're actually piloting. So the other thing I'll say is that leads me to believe that these rigorous adaptation processes are great, but there is nothing like actually piloting it to bring the full, bring everything to the surface. And so I think if I did it again, I would design the trial in such a way that there was like a micro pilot before launching the full pilot so that you could really capture those changes and make good on them. Yeah.
We are at the end of our time
Thank
today,
you.
so let's thank Dr. Bunn for her
Thank
Davis
you.
lecture
Thank
today.
you. Thank you so much.